I'll demonstrate HoLEP in an 82-gram prostate. These are two ureteric orifices. The bladder is trabeculated, as you can see. These are catheter-induced changes. The patient has been on catheter for last few days. These are two lateral lobe touching each other, and these are catheter-induced changes in the urethra. The ultrasound says it is a prostate of 82 gram. Ultrasound almost always overestimates the size of the prostate. So we started with our incision in the left lobe. I'm going to do a two lober technique. So this is how you develop the left lobe after just incision incising the mucosa. There's we go and lift the prostate, and after some time you'll get a very good plane. These are the adhesions, the fibers, the capsular fibers that are attached to the adenoma. As you move forward, a very good plane between the adenoma and the capsule is demonstrated. So I'm making a plane between the median lobe and the left lobe, and this is the 12 o'clock position. I'm making an incision very close to the sphincter of the urethra, and this is the most crucial part of the dissection. So once I have mobilized it, sometime you might see me cutting through the adenoma, especially in the uh, 12 o'clock to around 2 3 o'clock. But as I move from down and upward, I will find a good plane. This is the proper plane at the 3 to 12 o'clock position. My power settings are 2 into 35, a total of 70. So you can find few bleeders here, nothing to worry at this moment. So I'm trying to find a plane between the two lobes in the 12 o'clock position. I'm going very close to the bladder neck here, cutting the mucosa. And you have already noticed probably I have made the mucosal incision from the 12 o'clock, almost a curvilinear incision, up to from 12 o'clock, curving upward and then sweeping across the sphincter urethra to the verumontanum. So once find a plane between the adenoma in the lateral wall of the prostate, it is very easy to proceed with the further enucleation. Bleeder from the capsule, so slightly defocused, and then go ahead with the coagulation of the bleeders. Sometimes they are very adamant, and it's very difficult to completely achieve a hemostasis. But if you coagulate them for a while and then go ahead with further dissection, most of the time the bleeding will stop. And again, coming to the 6 o'clock position, mobilizing a little bit. So wherever I feel that my further movement is restricted by the adhesions between the capsule and adenoma, this kind of fibers, they're going to the adenoma. You cut them, and then you open up the proper plane and proceed. The entire idea is to connect the lines, from the 12 o'clocks to the 6 o'clock position. So I have connected the almost the entire line. I can go through the entire circumference of the adenoma on the left side, except at the 6 o'clock position, I'm still to reach the
We
bladder
started
neck there.
Kanya with the intent to celebrate medical professionals. The last couple of years have made us realize that
And so this is quite a significant bleeder. I will come back to that in a while. So let's go ahead. This is the arterial bleeding, which I have to coagulate. And I'll go through this bleeder once again. Once I have mobilized, most of them will stop. And if they still do, I can always come back and coagulate them. So even if you do a partial coagulation at this moment, most of them will stop, and only the most significant bleeders will remain, and you can always go and coagulate them. So with the newer laser, with the pulse modulation, the first pulse coagulation is or hemostasis is very good. And I don't have that machine at present. I'm using luminous 100 watt. So I'm at the 6 o'clock position, trying to find a plane between the left lobe and the median lobe. So I find it easier to go from down and then find the plane and reach the bladder neck than coming from the bladder neck down. I'm sure this is the plane, and I'll connect it to the lower point, and this makes the section easier. Once you have found the plane, the proper plane between the median lobe and the lateral lobe, we can just go ahead and then enucleate the adenoma. So at this point, I have already crossed the equatorial plane of the adenoma, and I'll stay very close to the adenoma. Otherwise, there is a probability of going subtrigonal at this region. So at any point of time, if I feel that I have left an adenoma, I'll go and further explore those positions. But yeah, as you can see, there is no yellow tissue left behind, and I'll cut here the bladder neck a little bit more, separate the median lobe and the left lobe, and this is how now the left lobe is completely free. So there is some attachment near the bladder neck, and I have turned my scope upside down. This is an adenoma. So this is a huge fiber from the capsule going to the adenoma. I will prefer staying close to the adenoma at this point, and the attachment, significant attachment that remains at this point will be at the uh, 3 o'clock or 4 o'clock at this region. Here also the possibility of going quite deep is real one, and the fibers are not as well defined as in comparison to other location. They are like more granular or kind of a fatty appearance in this location, in the close to the bladder neck at around 3 to 5 o'clock position. So once we go here, they open like fatty tissues, and I have to cut it here closer, and this is how I make the bladder neck a little bit more wider so that I can push the adenoma into the bladder. There is a significant bleeder here. Let's coagulate this bleeder. So with this laser, sometime you have to devote an extra time to coagulate, and then can still persist. And anyway, what I do is I always at this moment I always do check in the later part after all the morcellation and everything with the
I just booked
monopolar,
my flight ticket. Finally!
and
Guess how much I paid for it?
for the
6,000?
hemostasis, if I
4,000?
think,
नहीं
I
यार,
will go
just
ahead
26.
and do a hemostasis with the um, a loop. So I'm almost near to the bladder neck. So at this point, I have to be careful. I'm not pushing it too much, because if you push it too much, the adenoma goes inside and a lot of dissection remains. What is to be done is dissect it from the bladder neck, from both the side, and from and undermine what is remaining of the attachment of the adenoma. That way, it becomes easier. However, if you push the adenoma too much in the bladder neck, then the dissection might be quite a formidable one. So the idea is to let it hang like a mushroom, and then cut it base, and then cut it from the side both ways, come both ways if necessary, and then gently separate the lobe from the bladder neck. These are some of the mucosal bleeders. they might be very significant point of bleeding and make the feel dirty and during the morcellation process. So I'm left with only a very flimsy adhesions now, and we have dissected the left lobe of the prostate, and that is the some of the capsular vessels, and we'll go ahead and look after them in a while. Now let's focus on the right lobe along with the median lobe. So it's a two lobe technique, verumontanum here. So I'll incise transversely this portion, the median lobe, and we'll try to find out a plane the same way we did on the left side. So a plane is opening up in the uh, median lobe, and I'll come to the left lobe, sorry, the right lobe. Once I lift the median lobe a little bit more, then the dissection become easier. The trick is to cut the mucosa a little bit at a while and then dissect the adenoma. As you cut it, this is extra protrusion of the adenoma. We'll have to take this adenoma, so cut it a little bit and go under the adenoma, lift it up, and then you'll find a good plane. So let me see where I should connect. These are some of the fibers from the 10 o'clock to the 12 o'clock positions. Once I cut and then separate the adenoma from the sphincter, my dissection becomes far more safer. So here I have to be very careful, um, cut slowly, gently. So once I have found the plane, I can move a little bit faster here. Probably a part of the adenoma I'm cutting here, and this one here at the uh, 9 o'clock position. Let's coagulate this small vessel that transverses across the capsule to the adenoma, and I have already found a good plane, and here you have to go little up, and some of the adenomatous tissue sometimes remain, and it's quite difficult to take them along with the entire dissection. So these are the fibers. We are very close to the bladder neck now, and so as you can see, we have incised the entire mucosa of the prostate and separated it from the sphincter. Now gently we'll separate from the lateral wall. So I am doing the dissection as I move continuously both in the up and the down movement of my scope. There may be a small tissue left here behind, but we'll check it in a while. So see, the adenoma is not regular here. It has protrusion. It has a small adenomas in this location. And if I do a dissection too much, I might get a loss in the plane, and it might make my dissection much more difficult. So if there is any adenoma left after the complete dissection, the smaller one in the periphery going down deeper into the capsule, we can always come back and look for them in the later part of the dissection. But right now, it's important to go ahead and then remove the entire the main mass of the adenoma. And sometimes this small attachment, they will come of their own on the small adenoma, that extra adenoma. uh, Once everything is gone at the moment of scope, they most of the time they will come out, and without our realization they will be floating inside the bladder. So now I have crossed the equatorial plane, and I'm cutting the fibers, and I'm very close to the bladder neck, and you can appreciate the capsule. They are so well defined. These are the attachment to the bladder neck at around 11 o'clock position. Let me divide this one, and now I can come to the normal position. And so my scope is going from up and from down up, my so this is the last V attachment, and similar to the dissection of the left lobe, I have to careful now because I'm going up and proximal. Now I am not going deeper and deeper. This is the part you have to remember, and this is also the part where if we are fast, if we're pushing it, then we might actually go uh, subtrigonal. So will come, the mucosa will come down gently here. I might have gone a little bit deeper here in the subtrigonal area, and so cut from the both the side and then from under, and then we have almost done the dissection pussy. This is where I have gone a little bit deeper. Here we'll coagulate now. Let's find out what are the major coagulator, if any bleeder, if any. So gently we'll defocus and then we'll coagulate all the vessel, bigger vessel, visible vessels, and there's still some bleeder somewhere. Not able to see them. Probably, yeah, this is the bleeder. You can see probably the artery of flocks there, maybe a branch. Yeah, there we have coagulated it very close to the mucosa. These are mucosal edges. Sometimes they may be very difficult to coagulate. What the laser does, it bursts open the arteries and the vessels or the vein closer to the mucosa. So some venous bleeding can occur. If you give a slight traction, they stops usually. But the bleeder, we have to take care and then coagulate them properly. I'm at the 11 o'clock position, and we are gently checking all the possible area of bleeding, and then still a bleeder somewhere. Yeah, this is a small mucosal bleeder, probably. No, from the caps. Yeah, close to the cut edges of the mucosa here. Let us go to the other side. This is the entire sphincter, where very well preserved sphincter. And these are the adenoma. And we'll start our morcellation. The vision is okay at this moment. And so I'm using the same morcellator provided by the Luminis, and I'm satisfied with the morcellator. Then maybe there are better one in the market, but I have been using it for the last 5 years, and I have had no problem using this morcellator. So this is small, few small nodes there, and so the safety of the morcellation is on proper visualization. The adenoma should be moving and the bladder should be full. In fact, I use two irrigation at the same time. Ureteric orifice, safe, both side, no injury, small blood clot and few adenoma, chips of adenoma there. And we'll try to gently remove all of them. This is a blood clot already sucked out, and few cheese ball kind of adenoma. I think I finished the morcellation. Let's see the mucosa here. Is there any? Yeah, that is the mucosa overlying the sphincter. Very good vision. And I have coagulated a little bit more there, and the urethra you can see, and that was an uneven